Just a bit of introduction from me. I'm Francesco D'Ariensis, you all know me from the EPDA. And where are we here today? We're here today to give you an overview on the DBS sensing technology. And I wrote to an educated audience because we invited you who are members of the EPDA board and of the EPDA research interest group, because we are sure that you will already know enough about what the basics or deep brain stimulations are. So this is the occasion to share something more in depth with you, something about especially the use of the sensing technology, both in clinical settings and outside the clinical settings. We would like to illustrate what the impact of this technology can be on people living with Parkinson's and how it can improve the quality of life for people with Parkinson's. And we feel that this information disseminated to you as I said, representatives of the European Parkinson's community could be then disseminated more widely to the Parkinson's community more at large with your help. So again, thank you very much for being here with us today. And without further ado, I will leave the floor now to Fabienne Durat, Marketing Director Neuromodulation at Medtronic, who will go over what is the Medtronic DBS vision, just as a mean of introduction to the whole meeting. Thank you, Fabienne, and I will leave you to share your screen.
I think you need to stop sharing. Yeah, perfect. Thank you very much. So let me share my screen. Can you see the slides?
Perfect, thank you.
Perfect. So good morning. Thanks, Francesco, for the introduction. So my name is Fabienne Durat, and I'm leading marketing for our neuromodulation division, which includes not only brain modulation and DBS, but also spinal cord stimulation and other pain therapies. I've been at Medtronic for 10 years now, but I'm quite new to the neuromodulation. So that's really my privilege to be on this call and have the opportunity to share with you a little bit of our vision when it comes to deep brain stimulation and where we're going. So I'd like to share with a quote. I'd like to start with a quote from our president for neuromodulation. His name is Dave Anderson, sitting in the US. So how he sees the field of neuromodulation in general, and more specifically deep brain stimulation, is that he thinks we are now at an inflection point where we are moving from technology innovation to therapy innovation. And I will explain in the next slide what we mean by that. As therapy becomes personalized and improve outcomes, we can then to explore what else we can treat. So quite an inspiring quote, and I'm going to try to explain a bit what we mean and how we see the future of deep brain stimulation. So our vision at Medtronic is to be the undisputed leader in neuromodulation, improving patient lives through innovative solutions. How we want to do this is through three main pillars, which are technology innovation, therapy innovation, and expansion. So let me explain a little bit about each. So by technology innovation, what we mean is how do we make our platform, our device better? So how do we make longer lasting with improved battery technology? How do we make it smaller, more comfortable for the patients? And how do we make it smarter? And by smarter, we mean at this stage, how do we incorporate sensing capabilities in our devices? The second aspect is therapy innovation. So when we have this smart and very strong technology platform hardware, how do we make our therapies more personalized, more unique, more adaptive? So that's really the challenge that we're facing now, which will be key to really deliver a personalized therapy and truly improve outcomes for our patients. The third aspect is building on the strong foundation of technology and therapy. How do we increase the access to our therapies to more patients, more people around the world in our current indications like movement disorders, but also looking at how our therapies and devices could help people with other conditions. So we try to look beyond what we treat today, but we know that already today our therapies is largely underpenetrated in movement disorders, for example. So there is a lot of room to do to make sure that we increase this access. So if we focus a little bit on therapy innovation, so where are we going? So our goal is to be able to deliver closed loop stimulation. So if we look at, let's imagine so that we have a person with Parkinson's disease who has one of our closed loop deep brain stimulation system. So what would happen to this person? As they go by the day, the system will be able to detect any shift in their brain state and adjust therapy accordingly, meaning adjust the timing, the dosage, the duration, so that it really adapt to whatever is happening in the brain and in the activity of this patient. So this is the future. It might feel a little bit like maybe science fiction, but actually this is really close. So this is the near future. Where we are today is with our Percept PC device that we introduced a year and a half ago, we are able to provide sensing. So it all starts with sensing, because before being able to deliver a closed loop therapy, we need to be able to sense and detect brain signals. And these brain signals are actually correlated to clinical symptoms. So I'm not going to go into the details because first, I'm not the expert, and we have real experts on the phone that will explain that to you much better than I can do. So the goal for us now, we have Percept that is able to sense brain signals, and we are studying how with these brain signals, we can adjust therapy. So with closed loop stimulation, we'll be able to adjust electrical stimulation automatically, so no external action needed, based on how the signals are fluctuating. So this is really the future that will enable to deliver more personalized therapy with hopefully improved outcomes for people with Parkinson's disease. Then as we incorporate artificial intelligence, machine learning, data-enabled therapies, our goal is to truly deliver personalized medicine. So make these therapies more and more personalized and individual to each and every person to improve their outcomes. So that's the vision. This is really exciting, but of course it comes with a lot of challenges. So first of all, sensing is not easy because the signals that we're detecting are actually 1 million times smaller than the therapy we're delivering. So it already comes with challenges, but this is where we are today. But we also have a big challenge around data. To do this, we need data. And as you know, today, there are a lot of constraints around data collection, data storage, transfer, access, utilization. So we also need to invest a lot of time and effort to understand how we're going to use and store the data that we need to deliver this personalized therapy. So that's how we see the future of DBS. I hope you are as excited as we are. And during the course of this morning, you will learn more about where we are today with sensing, how it can help people with Parkinson's disease, and how it can be used in clinical practice. So thanks for your attention, and I wish you a very nice rest of the meeting. Thank you. Thanks, Francesco.
Thank you very much, Fabienne, and really fascinating, and looking forward to the rest of the presentation. Obviously, the topic of data, we all know it's fundamental now with the new technologies, and also in medicine especially. So, and it's a topic that's very important for us as well. So, yeah, thank you very much for putting the stress on this. Now, I will now hand the floor to Thomas Brionne, Principal Clinical Scientist at Medtronic, who will go more in depth about what is sensing technology for DBS and how we'll focus on the innovation aspect of this new technology. Thank you, Thomas, and I will leave you to share your screen.
Thank you, Francesco. Can you hear me okay?
Perfectly.
Good. Okay. So good morning, everyone. My name is Thomas Brionne. I work in the clinical research department at Medtronic and specializing in deep brain stimulation. And I will go indeed of what is sensing for DBS and really try and understand a bit more the technology about it. And the technology, we call it BrainSense. So it's, if you want, it's the product name that we use. But I'm going to put this in a scientific context. And then the two physicians we have will talk about the actual clinical practice, the actual impact for people with Parkinson's disease. So for BrainSense, I'm just going to explain why we need it, what's the need for brain sensing. I'm going to talk about local field potentials, what they are, and which are the ones that are very interesting for Parkinson's disease, how we got to where we are now with a device that's available for people that are indicated and where we can sense their brains if they're willing. And then just explain a bit on the actual technology. So what the doctor and the person with Parkinson's disease actually see, what is actually recorded, what does it look like on the tablet and on the patient programmer. So the need for brain sensing really comes from the fact that we need to listen. In diabetes, we have glucose sensors that can measure the amount of sugar in the blood and the skin, so they can tell how much glucose is present, how much insulin is needed. So instead of people with diabetes just injecting themselves with insulin, they need a readout. And having a pump that can read obviously makes everything simpler and more precise. Same in the cardiac space. A pacemaker, instead of just blindly pacing, can actually listen to the heart rate, see what's happening, and then stimulate the heart in the way that is required. And in the case of neurology, that's so far, our devices have been blind. They did not have, like a glucose measurement or like a heart rate rhythm measurement. They didn't have those biomarkers to listen to in order to change the stimulation. And that's what we're changing now with sensing and BrainSense in particular. So the reason those markers are important is that just like your heart rate can change depending on your activity, or your glucose level can change depending on what you eat, but Parkinson's disease changes. It changes from person to person. Not everybody has the same course of Parkinson's disease over the years, changes over time. Beginning or the end of the day will be different. The DBS is applied continuously. So it's always on, always stimulating in the same way. Programming can be difficult. So the physician changes some settings, the person with Parkinson's, does some motor test, explains, and then goes home. So when you're in the office, you have a few minutes to talk with your doctor, and that's it. At the end, you're on your own. You have to make your own diaries. You have to write down, explain to your family maybe what's happening, but the physician is not there. So there's a lot of variations over the years, over the day, over the month that we don't always see. And more specifically, during the day, that the Parkinson's state changes, usually related to medication, whether you took the medication or not, and whether the medication is working or not. Now, in the case of DBS, it's usually a flat line. If you want to change it, you have to have a device where the physician lets you basically change to have a patient programmer where you can increase or reduce the stimulation. And it's on you to do it as you feel, but it's not automatic, of course. The hope we have with those local field potential biomarkers is that first the device can listen to them and track those LFP dynamics, so the local field potential. I'm going to explain this a bit more, and look how they correlate with the symptoms, the medication, and the stimulation. So I'm going to go into more details about this. And the idea is that all of this happens not in a lab, it happens in the device. So throughout the weeks and months in between the hospital visits. In practice, to record brain activity, there's many ways. So this is, if you want to cut through the head, where you see the skin of the scalp and the bone, and then you're under the bone, and then you have the brain with the cortex and the neurons. And in DBS, we go deep. That's why it's called deep brain stimulation. But there's many ways to record the brain. If we go only at the highest level, like on the scalp, you can have an electroencephalogram, the famous EEG, where you just stick electrodes on your head. And people like me are bald is great. You have great electrode, it's stuck, but if you have a lot of hair, you have a lot of cables, it's not really nice, and you cannot walk around with this. Then we have electrocorticogram, where you insert electrodes, on the surface of the cortex, but you have to go through the bone. So you're not going to do this just to listen. There has to be a reason. And then you can have local field potentials that are deeper signals, if you want, where you're really looking at a smaller group of neurons. And if you're a neuroscientist, you know about action potentials, and those are basically individual neurons. So this is very precise, and you can measure those only in the operating room because you need very special electrodes. So what we chose among all those various ways of recording the brains were local field potentials, because you can record those with the same DBS lead that you use to stimulate. So it's a way to track the brain activity without adding any new recording hardware in the brain. We're just reusing the lead that is already in the brain. Now, what do we measure? So here is the intensity, so it's how much signal there is. And here is the frequency. And you can think about it as a pitch for the musical notes. So this would be the bass notes, and this would be the very high pitch sounds, high frequency. And scientists over the years have classified those various notes, those various frequencies in bands. And in Parkinson's disease, the ones we find most interesting are usually in the beta range, so the sort of 1830 hertz. But the gamma range that is much higher is also interesting because it could be potentially led to dyskinesia. So when there's too much activity, beta has been associated more with not enough activity, more with being blocked, like when you're off. So among all those various frequencies, in the case of Parkinson's, these are the ones we're most interested in. But for other diseases, it could be other types of frequencies. So in the past, the only way to record those frequencies in detail was, having the person with Parkinson's disease connected to an actual external recorder. So during the implantation of the DBS lead, you can put down electrodes and record what's happening in the brain. You can also record what's happening in the muscles. You can do your own movement and then have recordings, but that's obviously in the hospital. Then other hospitals did some tests, say, okay, after we've closed everything, can we record while the patient is walking around or standing or sitting? And in that case, they needed to have leads also going out, extensions going out of the patient's head and into an amplifier and recording laptop. So again, this is great for science, but this is not practical for everyday use. So the goal of Medtronic was to transform all of this into a portable system that was actually inside the device. So you're getting a device for DBS if you're indicated. For Parkinson's, you're getting DBS. And then on top, that device has chronic sensing. So the first device, maybe you heard about it, was Activa PC+S. It was not widely commercially spread because we wanted to test, is it possible to just use this box and the regular DBS leads and record brain signals? And the answer was yes, but we needed to improve a few things. So we created this one, the Percept PC, that has better shape and all kinds of other things, but specifically has the BrainSense capability that's built in. So we don't need anymore all those externalized leads, and we just use the existing DBS system that is already there. And the reason the system is there is to treat the symptoms. So the sensing is a bonus, if you want, it comes on top. So what we know from the literature, so from the scientific research that was done already before Percept existed, was those beta bands correlated with the UPDRS-3 score. So this is the motor score that you test in the office for Parkinson's symptoms. And there was a nice correlation so that when you have a lot of beta, you would have a high impairment in motor usually. Bradykinesia is also a correlation, so slowness of movement. And then for the things like side effects could be correlated with other types of frequencies. What was interesting is that medication and stimulation also influence those beta frequencies. So that if a patient would take their medication and they would work, then the beta would go down. And then if a patient would receive DBS and it would work, then also the beta would go down. So this is not 100% of the time. This is not 100% of patients, but it's something that kept being repeated by various groups around the world. And you will hear today of two leading scientists there that can tell you about the actual clinical setting and the actual clinical practice of this. So it's not all the brain frequencies, it's not everywhere in the brain, it's only recording at the sites of the DBS implant and only at the frequencies that are interesting for us. So how does it work practically? So I'm going to go over the various steps, the various things you can do with the device, and let's go through them one by one. The first one is the setup, is really to check where are we going to record from. So this is the end of a DBS lead that you've seen. This one is the regular one, but you'll see there's other types that can work too. And you can stimulate like in the green contacts. And then you have to record using the contacts above and below. Because as Fabienne said, the difference between how much stimulation you give in the brain in a give contact and how much listening you're doing, the brain sensing listening to your own activity is 1 million times different. So what we're using is there's the contact above and the contact below are used for recording. So the center stimulates, sends the electricity, and the sides listen. Now, it's important to have this quality of signals that there's no noise. And one of the things that could make the noise is actually your heart rate. So we call that the ECG artifact, and the device tells you if there are artifacts, if there are problems in the signal. So some people, if they have their device very close to their heart, or there's some fluid leakage, maybe you will start seeing the heart rate. And we don't want to listen to the heart, we want to listen to the brain. So there's ways to fix it or to clean up the signals. And another one is movement. If you're very active, so the cables are moving, these could create some noise in the signal. So that's why when you do the first test in the office of BrainSense, it's better if you're seated and calm, so that there's no movement or problem to have basically a jamming of the brain signals. So this is just the beginning. Then these are the actual 4 functions that are most interesting, and I'm going to go over there one by one to see sort of what are we listening to and when and how. So the first one is the BrainSense survey. So it's the very beginning. So what it does, it's an automated scan, and you see here these numbers. They're the numbers of the contacts in the DBS lead. So here there's no stimulation. It's really a scan of going through all the contacts of the DBS lead in the brain to see what type of frequency. So you remember the previous drawing with the intensity of the brain signal here, and then the types of frequencies like the pitch. So with the bass, the low frequency on the left and the high frequency on the right. And the device just goes through all of it and tries to find, is there, for example, a beta peak? So is there a pair of contacts that when you listen there, you're getting that beta frequency, you're getting that note that is associated with a reduction in movement. So is it present? At which frequency? From which contacts? Are there any problems? So this is really a check. And what is important is, as Fabienne was saying about personalized medicine, this is your beta frequency at this moment in your brain with this lead. It's a very unique, not everybody will have the same one. And that's the whole point of this device, is your frequency at a certain time in a certain state. And this is the one that the device will then record, because this is the one that is most interesting. So it's important to do this first check to see what is your frequency of interest at this time. So it's really the first check. And if there's nothing, while that happens, we can try and fix it. And sometimes there will be maybe one side that will not have any good recordings and the other will have one. So far, we've seen that most patients actually have at least one of the sides of the brain with a usable frequency, but not everybody will have one. What's important also is that these are the old leads, if you want. Now we have new leads called Sensite that have 3 contacts in the middle, and we can also record from them. So because they're smaller, there's different types of calculation on how we do the recording. But the idea is that we're getting also brain sensing on the directions. So we're not only recording from above and below, but we're also recording, if you want, around, as a way to try and map where is the strongest brain signal to use in the future. So that's actually a good thing, because the lead was designed to enable sensing also in a somewhat directional manner. So now that we know where to record and which frequency to pick, we can move on to another thing that happens actually outside of the office, which is the BrainSense timeline. And this is really, for me, the game changer, because what you see here, instead of being just a few seconds of recording, is you see a calendar date. So that's the day of the month with the little squares. And below you see one day from midnight to midnight. Here you see the amplitude, just like before, of the frequency. But this is only a small frequency that you picked. So earlier, we scanned all the frequencies and say, okay, my beta is at 18 Hertz. So this is giving you a small band around those 18 Hertz. And it's doing averages, if you want, of 10 minutes of brain activity recording throughout the day. And why does it go up and down? Well, it could be the medication. If you take your medication, the beta should go down. If the medication stops working, then the beta should go up. If there's certain activities, or if you're sleeping, the beta will change. And this is really like maybe you've done a motor diary, like when you're logging your activity every 30 minutes. This is like a simplified version of your brain activity throughout the day. You can do up to 2 months of recording. So it's not going to be for a full year, but you can only do 2 months. But it can record on the left and on the right. And then at the bottom, you see the stimulation. So the beauty of this is automatic. Once it's set up by the doctor in the office to record at a certain time, you're getting this recording. You don't have to do anything. It's just doing the recording. So it's recording from the DBS lead at the site of stimulation. And that was never done in the past because you had to be connected to a machine. No, this is all happening inside the device. The only limitation is the power and the memory. So that's why you're getting only 2 months of recording, because otherwise there would not be enough space in the device to record. Now, what you can do with that in collaboration with your doctor is to check, when are you feeling good? What is a good amount of beta to have? The goal is not to destroy the beta. The goal is not to increase or reduce, is to keep it in a nice band. And the first thing that the physician can do in collaboration with you is to define what is the right amount of beta. When do you feel good? What's the amount of beta in the brain? And then the device can classify how much time did you spend in a good state or in a bad state. So what we hope is that using those numbers, when you go to your physician and say, well, last week was not good, I was shaking a lot, I was being too strongly stimulated, there was these dyskinesias, maybe they can look if indeed, maybe you did not have enough beta, or maybe you had too much gamma if they're recording gamma. So it's a way to quantify the brain activity and have a sort of measure of the diary. So we don't know yet how useful it would be, but the device right now is ready to do that and to give an objective readout of the amount of activity, at which level, how much brain activity was there. So that's for the timeline. And then you have an option to participate in this, so to add things called events. So the timeline was completely automatic. For the events, you have to do some work. So the timeline events, let me see, actually here, you see those pluses. These are examples of events where the person with Parkinson's triggered events. So what do? They take their own patient programmer. So you see it's different from the old ones because it's more like a smartphone. And it has some events that can be set with the physician at the beginning. For example, I'm feeling on, my meds are working, I'm feeling off, I feel blocked, but dyskinesias are moving too much, or I just took my medication. So this requires your intervention, your work. You press on the button, and what it does is that it triggers a recording of all the frequencies in the brain for 30 seconds. So it's a snapshot. So it's not going to give you 2 months, but it's going to give you how are the frequencies around that DBS lead at that moment. So it's a big spread. So for example, if you feel off, there could be potentially a beta peak at that time because you're a bit blocked. So there could be a way, but you're also recording the various other frequencies. So it's a way where you need to work. You have to take out the device, press the button, but it's a way to get a snapshot. And then when you go back to your doctor, say, well, yes, I had these particular things, and they can look at what was happening in your brain at the time when you press the button. So it does not tell you what happened an hour before or an hour later. It just gives you like a 30-second snapshot. So it's a way to add more information to explain what's happening in the brain at that time. And then the last one is BrainSense streaming. So streaming is something that has to happen in the office. So it's a big difference from the timeline or the events. And as you can see here, it's moving, it's live. So if you're streaming, Netflix or a TV series, here you're basically streaming your brain. So the brain activity around the DBS lead is shown in the top one. So for example, this is the beta power, so that frequency of interest that changes. Below is just a zoom out, if you want. It's for what was happening during the entire doctor visit. And then below is the stimulation. And what's interesting here is that the doctor can change how much stimulation you're receiving. But at the same time, instead of just looking at you and seeing does tremor stop, or is there some, some facial pulling or some speech problems, they see this because they see you in the office, but also at the same time, they see the brain activity. So it's a way to have, on top of the usual classical medical science, which remain the gold standard. We should always stick with those. But on top, the doctor can see on their tablets what's happening live in terms of that particular frequency in the brain. So it's really a way to get readout that's objective, that's not based on observation, it's really based on just a number. Here's the response of the brain, if you want, to the stimulation. So that doesn't mean it's the end of doing actual tests. You need to still be measured and tested, but it's a way to add numbers, to add live visualization of what's happening in the brain. And that can only happen in the office. because it's, you see, it requires work, and also it does transmit a lot of data. It's using more power, so you don't want to spend months and months draining that that power by using streaming. Streaming is really for an in-office visit. It's a live test, and that's what it's used for. You can really judge the impact of the stimulation, and you can see what's happening live. You can also use it for sitting or standing or even walking. So it's a way to measure what's happening in the brain while you're doing some specific activities under the guidance of the physician. So I'm gonna stop there. All of this is obviously technical features, but there are scientific references. I'm not gonna go in them, but we'll see how much we can share afterwards about how the science arrived, how this technology arrived. And then I'm gonna just end with disclaimers saying that there is, I'm not gonna go into detail, but this is a medical device, obviously need to be indicated for it. And the physician knows, how to use it, what are the things that will be relevant or not for each person with Parkinson's. Not everybody will have a signal, not everybody will have signals that are very useful for them. But some people may have, may have a benefit from this additional piece of information, both in and outside of the clinic. So really, this is really just to start a discussion with the physician on, is this worth it? Is there an interest in those signals? How are they going to be useful or not for each person's individual case? And then now it's time to give the floor to the actual medical doctors. I'm just a neuroscientist, and they can share their actual experience with people with Parkinson's disease and with sensing in actual medical practice. So thanks a lot for your attention.
Thank you very much, Thomas, for this very, very thorough and interesting presentation. And yeah, it's extremely fascinating. And the idea of being able to actually see and track what's going on in the brain, as I think you said, or Fabienne said at the beginning, it may sound like almost a science fiction, but instead it's very good to see it's there and working. And yeah, and it has huge potential and possibilities for treatment. Now, I will, to continue the session, I will hand the floor to Professor Andrea Kühn, who will explain more in detail how the sensing technology is used in clinical settings. So, Professor Kühn, I will stop sharing and leave you to share your own presentation. Thank you.
Thank you. So I hope you can see it.
Yes, perfectly.
Yes. Okay. So you have already got a very nice introduction on all the technical advances for sensing possibilities with the Percept, and I would like to show you some examples from our clinic. So as you all know, deep brain stimulation in movement disorders is a very successful therapy. And we have class 1 evidence that favors deep brain stimulation for treatment of motor deficits in Parkinsonian patients and also for quality of life as compared to best medical treatment. We also have very good effects in tremor patients and in dystonia. However, even so, with these very good clinical results, there are still some open questions and also clinical needs. So there's still an ongoing discussion of the definition of the optimal target. And we know that the optimal targeting is one of the most important prerequisites to get a very good effect in our patients. Also, we still don't understand sometimes how to avoid side effects during stimulation, especially the delayed onset of some adverse effects like bradykinesia in dystonia patients or ataxia in tremor patients, but also dysarthria in Parkinsonian patients is a major problem in some patients. So at the moment, we treat all these main movement disorder symptoms with the same therapy, usually 130 Hertz of stimulation 24 hours a day, and irrespective of the fluctuation of motor symptoms. So the overall goal is to treat symptoms of brain disorders by targeted network neuromodulation, so symptom-specific and also time-specific. And one way to understand better how these symptoms develop and which networks are involved in the generation of some of the symptoms. We have used electrophysiological recordings over the last 20 years to characterize brain network activity. And here I show you an example from a recording from the subthalamic nucleus. So we used recordings from the target areas for deep brain stimulation, and this is mainly the subthalamic nucleus in Parkinsonian patients. And we can record from the electrode brain activity, so-called local field potentials. So this is like an EEG of depth of the brain. And we can combine this with an EEG of superficial brain activity, or MEG, magnetoencephalography, as you can see it here. And that helps us to understand the involved motor network, which includes the motor cortex and the basal ganglia. And by characterizing the changes in this motor network activity, we have related this to symptoms of the disease, and also have explored how stimulation modulates this activity. And I will show you this, and then show you the way of how we can use this information to optimize therapy in the patients. So here you see an example of a recording from the subthalamic nucleus in a Parkinsonian patient over a whole on-off levodopa cycle. So at the beginning of the recording, the patient did not take any medication for 12 hours. So he's in a defined off medication condition and very bradykinetic, rigid. And then the neuronal activity has a very characteristic pattern. And that's on the left part of this time frequency plot. And you can see here in the yellow colors, the predominant activity. So the more yellow or red the colors are, the more prevalent is this activity. And that's in the so-called beta frequency range. So around 15 Hertz here in this patient. And that's a bit fluctuating over time, but very prominent activity. Then the patient takes a levodopa dosage, so 200 milligrams of levodopa, and within half an hour, the beta activity drops, and you can see that this yellow marker disappears, and within a certain time period of several minutes, an activity in the lower frequency range occurs. So in the theta alpha range, around 6 to 10 Hertz, which is associated with dyskinesias in the patient. And when the peak dose dyskinesias occurs, so 1 hour after intake of the medication, additionally to this low frequency activity, also gamma activity occurs in the range of 70 Hertz. So what you can see here in this picture is that there's a pattern of neuronal activity that is associated with a change in motor symptoms in the patient. So we have a state-dependent biomarker here. Beta activity is only present when the patient is bradykinetic, but when the patient, when the motor state changes in the patient, then also neuronal activity changes, or it's rather the other way around, we would hypothesize. So neuronal activity changes, and that leads also to a change in the motor state with the reduction of bradykinesia, and in this case here, the occurrence even of dyskinesias. So we can use this information for adjustment of the therapy. We have further analyzed this in a large cohort of patients. So this is 62 patients here, where we analyzed these local field potential recordings from the subthalamic nucleus, and we calculated the beta frequency, so the power of this beta activity. So you can see on the upper right corner, this is a typical power spectrum with a large peak in the beta frequency range. So here around 18 Hertz in this patient. And we calculated the amount of this beta activity and correlated it with the motor state as measured by the EPDA score in the patient. And as you can see here, there's a significant correlation. So the more beta activity is present, the slower, the more bradykinetic are these patients. That helps us to show that really beta activity could be used as a biomarker for bradykinesia and rigidity in these patients. And we also could show that this is consistent over time. So usually these recordings were only possible 2-3 days after surgery. We have a 2-step procedure in Berlin where electrodes are inserted at the first surgery, and then a couple of days later, these electrodes are and the leads are connected to the brain stimulator, so the pulse generator. And that gives us the opportunity to record this brain activity just a couple of days after surgery. With the first set of sensing devices from Medtronic, the so-called Activa PC+S device, we had the chance to record for the first time patients over longer time periods. So here you see an example of this study where in 10 patients, we recorded brain activity not only at baseline, which was a time of surgery, but also 3 months later and 8 months later. And what we could show is that this beta activity is a very consistent biomarker over time. So again, here, when you look at the lower panel, you see this activity in the yellow colors, so the prominent activity in the beta frequency range, and that even seems to enhance at 3 and 8 months a little bit because we have an edema after electrode insertion, which also reduces this beta activity. The middle panel shows the power spectra, and the blue line is in the off medication condition, and you see nicely this beta peak that is also prominent at 8 months. So it could be a biomarker that still reflects the motor state even after continuous deep brain stimulation. And these recordings here have all been taken without stimulation. So when the stimulation is switched off, this beta activity reoccurs in parallel to the reoccurrence of the motor symptoms in these patients. What else could be helpful? While we not only analyze this beta activity over time, but we also try to localize it within the subthalamic nucleus. We know that the subthalamic nucleus, even so it's a very small nucleus, we want to target the dorsolateral part of it for optimal position of the electrodes. And we have now analyzed in a large cohort of, again, these 62 patients, the maximum of this beta activity for each individual patient, and that's shown here. So on the right side, you see enlarged the subthalamic nucleus, and the motor part of the nucleus is shown in yellow. And exactly in this motor sub area of the subthalamic nucleus, we have the maximum of the beta activity. So it really could help us also for targeting to define where the optimal place for stimulation would be for the electrode, and also in the future then which contact we could use for stimulation. So let me summarize on from our experience what could be useful indicators and why we could use this chronic sensing in clinical practice. So as I showed you, beta activity is a good biomarker that can help to identify the hotspot, so the best location for deep brain stimulation electrodes, to define the best contact for stimulation. Also because we know that stimulation also reduces beta activity and it reflects the motor state, we could use it to adjust the stimulation amplitude. And I will show you examples for this in a minute. And ultimately, of course, it is the biomarker that we aim for to adjust stimulation over time and use it as a feedback signal for adaptive stimulation. So why would be adaptive stimulation interesting in Parkinsonian patients? While in general, movement disorders often occur intermittently and are variable over time. But especially in Parkinsonian patients, this is the change from off state to dyskinetic states that can fluctuate with medication over the day. And chronic stimulation, I showed you at the beginning, have not only additive effects with medication that leads to dyskinesias, but also have side effects like dysarthria. And we, of course, intermittent stimulation would also save battery life, but also from a physiological point of view, intermittent stimulation is a completely different approach that might induce plasticity in the brain and network effects that we still don't understand, that hopefully would even lead to a better effect of the stimulation and maybe even less need for the amount of stimulation over time. So it could induce some changes in the motor network that needs to be explored. So where are we now with the Percept? We have operated the first patient in January 2020. And since then, we have operated on 32 patients. Most of them are Parkinsonian patients, some dystonia and tremor patients. And here you see our neurosurgeon on the right-hand side, and on the left-hand side, that was our first patient. She already had an implanted device, and that was a pulse generator exchange in this patient. You see a snapshot of the montage screening recording, which shows a very nice recording without artifacts here in this patient. So why do we need this chronic sensing? Well, I already said it can be used for optimal stimulation amplitude setting, optimal contact selection, but also the long-term follow-up for treatment adjustment, not only adaptive stimulation, but adjustment of medication, for example. And I will go into more detail for the first 2 points, and then Fiorella Contarina will also point out more the long-term follow-up, which are not in clinic, but during the activities of daily living, which is a great opportunity using the Percept in a large cohorts of patients outside the lab conditions and outside the hospital. So let me show how to use it for parameter optimization. So you have been introduced already to the BrainSense survey mode. So this is a sensing mode of stimulation. It's very short and quick, and you can get an overview on the activity for each contact, and you get a power spectrum at the end of this survey. And you can define there the contacts with the best beta activity, as shown here on the tablet for the moment. You can define the peaks, and on the right-hand side, here's an example. And here you can see that, so for specific selection of contacts, we get a largest peak, and this could be used to select the contact for stimulation in these patients, because we would like to stimulate at the contact with the maximum beta activity. And I've shown you an example here from a recent recording that we have done. So with the SenseSight electrodes, we even have, for the 2 middle contacts, 3 segments each. And that is even a more difficult decision in clinic to test this all with standard clinical testing. That takes a lot of time for the physician, but also it leads to fatigue for the patient. So it would be good to have a pre-selection of contacts based on electrophysiology, for example, that can then more specifically be tested in clinic. And that's shown here. So these are different bipolar recordings, so it's always a pair of two contacts that are where the activity is recorded from. They are marked in orange. So on the upper left corner, it's contact 1A and 1B, and then 1BC. And as you can see, when combining contact 1A and 1C, we have the largest amount of these beta activity. And when we then reconfigure the contacts and we combine 1A and 2A, and then 1B, 2B, and 1C, 2C, we see again contact 1C and 2C has the largest activity. So we should explore in this patient, especially contacts 1C, 2C, and 1A for a best constellation of parameter setting. And in a study that has been done by Peter Brown's group a couple of years ago, they showed that when using the contact with the highest beta activity and the second highest beta activity, that would be the same contact that also have been selected by clinical standard of care in 84% of the patients. So, but the exploring this clinically takes a lot of time, and it could be then used as a good basis for a contact selection, these electrophysiological data, and there are more studies underway to explore this constellation. And I think that would be very helpful in the future to use the chronic sensing for this pre-selection of potential good contacts for stimulation. Well, let me show you the BrainSense streaming. So as it has been said, that's usually done in the clinic, in the lab condition. It is a real-time evaluation of stimulation effect that's possible here. So you have seen this on the tablet already, and I show you the data that we have recorded in several patients to explore how to adjust the stimulation amplitude in this setting. So we know from different studies that this beta activity is suppressed by stimulation. So if you look at the left-hand side here, that was the time when we didn't combine stimulation and recording. That was not possible at that time. But we have a stimulation setting that's the red, demonstrated here by the red bar. And in the upper trace, you can see hand movements of the patient. So large hand movements are possible during stimulation. Then the stimulation is stopped and the recordings are started, and the beta activity reoccurs over the time of a minute here in this patient. And if you look at the hand movements in the upper trace, they get smaller and smaller with the reoccurrence of beta activity. So beta activity is a good biomarker that parallels again here the change in motor state. And I show you now a similar condition with a patient with Percept in the video. So this patient, she was operated 3 months before this recording. So now we can explore this stimulation effects several months or even years after surgery. And here you see this, the patient without stimulation, so the hand movements are slow. And when you look at the lower right trace, there's a lot of beta activity, so around 14, 15 hertz in this patient. Now the stimulation is switched on at 1 milliamp. You can see this red bar on the right upper trace that indicates the stimulation amplitude. And we have done in our study a stepwise increase of stimulation amplitude from 0.5 milliamps for each step. And I show you just a few of this here in the video. So now with 1 milliamp of stimulation, the movements are still quite slow, and there's suppression to some degree, but not complete suppression of the beta activity. And we further increase the stimulation. So it's now 2 milliamps. And you can already see that the effect of the beta activity is more significant. So there's more suppression of the beta activity. The hand movement gets faster. And we already see quite a good effect. We now go up to 3 milliamps. So there's almost a complete suppression of beta activity. And also the patient can move much faster. And now the stimulation is switched off again. And if you look at the beta activity, that reoccurs within a few seconds. So when looking at this in a larger subset of patients, I show you here that we could show that really hand movements improve. So that's the upper trace. So with 1 milliamp of stimulation, the hand movements get already larger. With 2 milliamp, significantly larger. And when the stimulation is stopped again, then the hand movement amplitude is reduced. And in parallel with this, when you look at the lower trace and you look at the red, yellow activity pattern in the beta frequency range. So there's a lot of beta activity without stimulation. And when you look at the 2 milliamp, the beta activity is nicely suppressed. And that's shown in these averaged plots for all patients, that we really have a stepwise decrease of this beta activity with increasing stimulation amplitude. And at the same time, as the beta activity decreases, also the hand movement velocity gets larger. So I don't go into detail here. It's more specific for the beta activity. Really, this is what we show here. And it's not, this change is not seen in the alpha or theta range. So it's really a very specific change in the beta activity. So let me show you this again here with stimulation of a single segment of a segmented lead, so a sensite lead. Again, we can see here with stepwise increase in stimulation amplitude, which is documented with a red line, we get a further suppression of the beta activity. And this can be used to explore really which segment is useful for stimulation and also which amplitude can be used to sufficiently suppress beta activity in these patients. So I skip this and I come to the last bit of my talk. Here, the chronic brain sensing signal check is what you do first. You select a contact for the chronic brain sensing during stimulation. So that's shown here as an example. So contact 1 is stimulated in this patient, and then the sensing is from 0 and 2 as the 2 adjacent contacts. And we can set this up for chronic monitoring in the patient, and the patient can go home. This is also the configuration that will be used for adaptive DBS settings in the future, but that's not possible so far with the device, only within the ADAPT study, but not in clinical practice. And with this chronic sensing, as it's shown here again as an active therapy, we can monitor the beta activity or any other activity over days and months in these patients. And I show you here an example. So you see the sensing for several days in June here in this patient. So there's long-term monitoring possible, and it's a 5 Hz window of beta activity that is recorded and a data value that is extracted from it, the power value every 10 minutes. There's this special opportunity of an event marker that has been discussed before. And with this event marker, it is possible to get a full power spectrum from this single event. So from a 30 seconds recording that is also then saved for the patient. So if you set up a specific event marker, like let's say taking the first medication in the morning or going to bed at night, then we can analyze the activity with respect to these markers. And that's what we have done here in this patient. So we look at circadian fluctuations in beta oscillation. So the patient always marked the time when he went to bed. That's a green marker here on the lower panel. And the intake of the first medication in the morning, that's a red dot. So you can see really major changes between day and night with higher activity in the beta frequency range during the day, and large circadian fluctuations of this activity. We still have to explore this further, what the reason is for this change between day and nighttime. And I think Fiorella Conterino will go into a bit more detail on these long-term recordings. But it's very interesting to have the opportunity to monitor the patients when they are at home, when they come back to our outpatient clinic after 2 months, to read out this activity and see how the changes correlate maybe with the intake of medication in these patients. So this, what I showed you is that beta activity is a biomarker that can reflect the motor state of the patient. And this is what we need as a feedback signal for adaptive stimulation. So here's a schematic of the concept of adaptive stimulation. So we record this brain activity, and at the moment we think the most powerful would be to record beta activity in Parkinsonian patients. We give this to the processing unit, to the pulse generator, and this adaptive controller would adjust the stimulation. So we set a threshold at the beginning, and then when this beta activity is high enough to cross the threshold, the stimulation would kick in or would be increased in the amplitude and lead to a further suppression of the stimulation, and should go along with an improvement in motor symptoms in the patient. And it can be adjusted then according to medication intake, to activities of the patient, and so on. So there's a trial ongoing. So Helen Bronte-Stewart is leading the trial. Unfortunately, we couldn't do it in Germany, but here 2 modes of adaptive stimulation will be explored in a crossover design. And we are very much looking forward to get the first results. We have only seen a single case experience from the Japanese group that has been published with very nice reduction in stimulation time for these patients as long as they were in the hospital. So the results are still not available, but will be expected in the future. And I think it's a great first step to explore this opportunity. So finally, always, so I've shown you all the very interesting aspects, but there are also limitations, of course, and there are artifacts in some of the recordings. And there are 2 major artifacts that we always have to keep in mind when we interpret the data. And this is movement artifacts. So we record a very, very tiny brain signal. And of course, this is prone to movement artifacts when the leads that go along the neck are moved, for example, with head movements, we see these artifacts. And also the ECG artifacts are critical in some patients. So that's also a large electrical field around our heart that is much larger than the brain activity that we explore, and can contaminate these recordings. And there are attempts to avoid this by, for example, putting the pulse generator on the right-hand side. That is what we have shown for ECG artifacts. So here you see the electrical field of the heart. And obviously when the stimulator, the pulse generator, is put on the left side, these ECG artifacts are much larger as compared than the pulse generator is put on the right side for the patient. So that is a suggestion how to avoid these ECG artifacts. And there are other ways to then also clean the recordings from these artifacts afterwards. So I hope I could give you an overview on how we can use this chronic brain sensing, and that it opens up a great opportunity to learn more about the disease in a large patient population and explore the changes in brain activity once the patients leave the lab and are in their daily routine. And this is the part that Fiorella Contarino has explored more and will then show you some more data in her talk. So thank you very much for your attention.
Thank you very much, Professor Kühn, for this very detailed and really, really amazing and fascinating presentation. I mean, it was extremely good, especially to see, I mean, at least from my perspective of a non-scientific expert, to see the direct correlation between the stimulation and the effect, the practical effect on the person, the movement, and also to see how it can simply be controlled by a relatively simple device. So thank you very much again. Now, before we give the floor to Dr. Contarino to see how sensing technology can be used at home outside the clinic, we have a little coffee break. We are almost spot on time, so we have 10 minutes, and we will welcome you back here at 11:25. Thank you, and looking forward to see you later in 10 minutes for the next presentation. Thank you, Dr. Contarino. I will now give you the possibility to share your screen and your slides.
Yes, thank you very much, Francesco. I'll try to share now. Is it okay? Yes. Okay.
Perfect.
So again, thank you very much. I'm very pleased to have this opportunity to be part of this meeting and talk to you all. I think it's always very important when there are new technologies, new treatments, to talk together and see what's the mutual interest in this. And being the last speaker of the morning, I have also the advantage that a lot of concepts have already been touched upon. So maybe they are a little bit more clear, although I understand this can be very complex at times, and sometimes it's complex even for us that are busy with it. So I understand that some concepts are a bit complex. So I will try to go more into how this new technology, this possibility of sensing, is used outside the clinic. So the outline of the presentation is first shortly talk why do we want to do this at home. Then what are the potentialities that are offered by this new system for home recordings. And I'll give you some examples from the clinical practice. We also have now almost 1 year of experience with it, and some limitations that we have run into and what could be the future perspectives. So first question is, why do we want to do this at home? You have heard this already. I didn't know Thomas was going to use the same analogy, but this is maybe an easy way to explain the local field potentials. The local field potentials are recordings that we make from the brain. And we know that aggregates of neurons talk to each other and they communicate by using electricity. They're using these local field potentials, and this you can imagine as a music of the brain. And there are within this music different combinations of notes, and every note may have different meaning. So on one hand, we want to have the whole picture, the whole music. On the other hand, we want to focus on some specific aspects of it, so some specific frequencies. And the beta frequency is associated with rigidity and bradykinesia that you have heard already. So that's why we are now focusing mainly on this kind of frequency. So we call it the signature of the off period. Why is that? Because you have heard that when this frequency is higher, then it usually correlates with a higher degree of rigidity and bradykinesia, which usually means a higher degree of off. So when there is off, we measure a higher beta. When there is on, so good response to treatment, lower symptoms, there is a lower beta. Also, we know that this frequency changes over time. So this is a good marker because it can give an idea of the fluctuations, the motor fluctuations during the day. We know that it responds to medication as much as the symptoms. So when the symptoms improve with effective medication or with effective stimulation, also the beta frequency lowers. It has some relation with sleep, we will see in a moment, and it has some relation with movements and activity. So why do we want to record this frequency at home? The possibility is to perform 24 hours recordings of brain activity from the structures of interest. In this way, we could be able to record automatically and identify automatically the off periods from the brain recordings. Also, we could check sleep quality or sleep quantity. We could check the effect of therapy changes, so whether it is working very well or less. And in the end, we get a sort of digital diary from the brain. And why would that be useful? So there can be different scenarios. It could be that sometimes fluctuations are less clear. So most of the times when the patient comes back to the outpatient clinic, we ask, did you have off periods? Did you have on period? But it could be that this can be difficult at times. It's not always very, very clear, especially when symptoms are milder or are unclear, or there is an unclear transition between the off and the on. So sometimes can be difficult to identify this period accurately. Also, there are some symptoms that can be present both in off and in on. Think, for example, dystonia. So some symptoms are very tricky. And then when we ask the patient, did you have this symptom? Were you off or were you on? It can be very difficult to identify. And also we know that there could be good days and bad days. So when we see somebody after 3 months and we ask how long have you been off, sometimes can be very difficult because it can be good periods and bad periods. So what we also want to do is to monitor the efficacy of the treatments. So we change the medication, we increase the medication, decrease, add another medication, we change the stimulation. Sometimes, if you are familiar with DBS, we can set up different settings of stimulation. We can ask the patient to change them at home and see how it works. And there might be sometimes very slight differences between one treatment and the other, one program and the other. While for us, it is very important to know which one was best. So if we give 4 options, it's because we have a project in mind, and then we want to know which one is the best so we can go further with finding the parameters. But this can be very tricky when the differences are small, and especially if we ask the patient to try this treatment each for 1 week, then at week 4 maybe it's difficult to remember how it was in week 1, especially if the changes are little. So with all these situations, there might be even other clinical scenarios, but in these situations it could be useful to have also a signature from the brain that is recorded and that helps us putting down the off periods. So what can this new device do for home recordings? You've heard already that the first step is always to identify this famous beta peak. This is an example from a real case. Again, you see here, I don't know if you see my mouse. Yes, you see here the lead. It has 4 contact points, and the recordings are always made between 2 contact points. And in this example, you see here on the left all the possible combinations of contact points. And you see that from this combination 1, 2, 3, we have a very high peak in what we call the beta frequency. So we assume that one of these 2 contact points is the closest to this activity in the brain. So probably one of these 2 will be the best to be used for stimulation. Okay, yeah. So now that we have identified the best contact pairs and the best contact point, we want to stimulate at home. How we proceed? If we want to record without stimulation, then we can choose the contact pairs that measure the highest beta, and we have a nice summary of the situation, the condition at home. However, if we want to record and at the same time stimulate, then there are some limitations in the system. So we can only stimulate with the contact pairs that are around the stimulating contact points. So in this example, if we activate contact point 2, we can only stimulate from 1 and 3. And what we are going to do is to track the beta power continuously. And it is important to notice that we are only tracking the beta power. So you have seen that we can analyze the whole spectrum, the whole music, but this is only possible in the office. When we are going to do home recordings, we can only measure the beta power, which probably is still the most interesting thing to measure, but this is in a way also a sort of limitation. And then another good feature is we can measure continuously for 60 days. So the system can store recordings up to 60 days. Another interesting feature, you've heard about it, is the events. This is the new patient controller. Looks very fancy. It's just a mobile phone. And I have to say it's also very intuitive. And one of the features is that the patient can mark events. And events are situations that we have agreed upon beforehand. So we ask what is important for this specific patient. We want to track the off periods. Then we say an event will be off. We want to track the dyskinesia. One event could be dyskinesia. But we can also say we want to track dystonia. Then we mark one event dystonia. So we can personalize the events to the specific situation. Or we want to mark tremor, and so on. Then what the patient has to do every time, for example, if we select off, every time the patient feels, okay, now I'm off, just take the patient controller and push on the off button, and the system will record at that time the full spectrum, so the whole local field potentials, not only the beta. So this gives additional information on top on the information that we had already of the fluctuation of the beta. So to summarize, we have 24 hours the beta changes, plus on demand every time is pushed 30 seconds of the whole spectrum. So now I'm going to give some examples from the clinical practice. So this is a recording of one patient in one day. And you see here on the top, the left STN, and here the right STN. They can be recorded simultaneously. And the orange line is the amplitude of the stimulation. So you see on one side it was switched on, and on the other side it wasn't. In this case, it was not needed yet. And the yellow line represents the power in the beta frequencies during the day. Now, very obvious conclusion that we can see here is that in this first part, the beta frequency is lower than in the rest. And this is the night. So you've heard already that during sleep, these beta frequencies goes lower. We don't know exactly how and why, but this is something we see quite constantly in everybody. And you see immediately we can say, okay, then in this day, you woke up at 8. You know, this kind of information. And if you collect it across several days, then you can see the quantity of sleep that the patient is getting. But also you see in this case is relatively flat, but I've seen some recordings in which during the night you also see some peaks. And that could indicate that the quality of sleep in that moment is less, so it's a more superficial sleep, or the patient is awake and has to go to the toilet, for example. And also this you can monitor here. Another interesting feature is during the day. Again, you see that this goes up and down. And as we said, when it goes up, we expect that this will be the off period. And when it goes down, it will be the on period. So at this stage, we don't know yet. This is what we assume. I have summarized here an example of timeline recordings up to 10 days. So 3 days recordings performed 7 to 10 days after surgery. At this stage, the stimulation was still off. And what we see is that it goes up and down, up and down, up and down. And that is what we said, when it goes down is the night, and when it goes up, it is the day. So if we record this for 60 days, then you see that you have a nice representation of the circadian fluctuations. Okay, this is another example. So here again, as I mentioned before, if you look at the night period, you see that even during the night there is up and down. So in this case, in this day, this patient was not sleeping very well, for example. But another interesting feature is this purple squares. Those are the events. So every time that the patient pushed on the button and something is recorded. And what are these events? We asked in this case to record when he was off and when he was with dyskinesia. And what you see is that we get a power spectrum, we got a summary. And if you compare these two squares, then even with your eye, you can see that they are different. Now, even for me, it is difficult to say exactly which frequencies are different between this and this. This is not something to be done in this screen. This can be done in another screen and offline. But if you look at these two squares, you see that there is a difference. This one is more flat when there is dyskinesia, and this one is more bumpy and has peaks, and that's when there is the off. So we see immediately a difference. Now, we can also overlap all these summaries together. And what you have here in the top screen is, okay, this is in Dutch, but every time the patient has problems with tremor and with walking with small steps, so shuffling, you see again here, I have adapted to the very single situation of this one patient. I didn't say just off. I say you have to mark when you have tremor, you have to mark when you have small steps. And then this is the summary of all the events. And this is when the patient is walking well. That was the other marker. And our frequency of interest is marked by this blue line. That is a beta peak around 12 Hertz. And when we compare the beta peak in these situations and in these situations, then you can appreciate that here is much lower. So this is indeed an example. It's correct. In this case, with tremor and small steps, he was off, high beta peak. In this case, walking smoothly, he was on, low beta peak. We can also check the effect of treatment. We have heard already this. And here again, this is an example of the recordings with the stimulation off. And this is the same patient 15 days later. And now the stimulation is switched on. It is 2.5 milliamp. Actually, I think this is not off, but it is 0.5, so very low, anyway, ineffective stimulation. And this was the effective stimulation, 2.5 milliamps. And you see that the height of the curves is much lower, indicating that this stimulation is effective. So it is suppressing the total amount of beta. Now, this is all nice, but you've heard already, we are still in the beginning of this new recording. So there are some limitations. And what are the limitations? First of all, you have heard we focus very much on the beta, but unfortunately, the beta is not measurable in all leads. It is true that it is measurable in the great majority. More or less, we think 70 to 80% of the leads with F beta. But you can also have cases where you don't have beta at all in both leads, and then there's nothing you can do. Also, we have heard that it only correlates with rigidity and bradykinesia. So, for example, it does not correlate with tremor. And if tremor is the main problem, this could be less useful. Although we know that when rigidity is higher, usually is also the moment that tremor is also higher. So indirectly, you could still use it for other symptoms. We know that we're focusing on beta because the most well known, but maybe this is not displaying the whole pictures. Maybe to understand the complexity of the disease and the symptoms, we need to also have a look at other frequencies, other parts of the spectrum. And also the beta will change with on and off, but maybe this is influenced also by other things. And we have already seen the sleep. It is suppressed during sleep. It doesn't mean per se that this means on, but can also vary with movements, for example. So these are all things that we have to study better. You have heard about artifacts, ECG artifacts. That's a big problem, not present in all recordings, but when it is present, that could be a problem. And concerning the home recordings, movement artifacts are very important, because when we perform recording in the office, we can ask the patient to stay still for 5 minutes or 10 minutes and do nothing. But at home, that's of course is not possible, and it will also be not useful. So patient is doing sport, is going outside, is moving, is doing shopping, and these movements could provide an artifact that sometimes makes the interpretation difficult. Also, to mark the events, we need that the collaboration of the patient. So the patient has to be willing to mark every time on the mobile phone the event. And last but not least, this is an extra feature, and to run it it needs energy. So it's using some of the energy of the battery itself. Now, later, maybe in the question and answer, people from Medtronic can comment on this, and they usually say that it's not a large use of the battery, but even if it is a 15% of the battery, that means that this battery will last shorter and will be changed more frequently. What are the future perspectives? Well, this also you have heard already, adaptive closed-loop stimulation. It's a really hot topic, and you've heard about it. We are not there yet. So what I show you until now is only the recordings. And those recordings we just interpret, and based on the interpretation, we decide how to change the therapy. But the idea here is that these recordings go automatically into the stimulator, and the stimulator automatically interprets them and adapts the therapy based on what is recorded. Now, this will be really nice, of course, because that means that, first of all, it will be quicker to the best parameters, because we don't need to do the trial and error. What we are now doing, sometimes it takes up to 6 months to find the best parameters, and if the system does it automatically, that will be much shorter. It also means that will be more personalized. So every patient will have their own specific treatment in time. Also, it will be adapted in time. So good days, bad days, good moments, bad moments, sleep, sport, the system automatically adapts the therapy that is needed. So this will be really a great opportunity. The potentiality is already there, as you've heard. Unfortunately, it's not yet unlocked for us in Europe, but it is unlocked in Japan. And if we look in the literature, the Japanese team already have published the first patient who had this feature at home. And these are the recordings they made. I'm not going into this because I find it myself very, very complex. But the most important message here is that this is happening already. So this is a future that is very close to us. It's not a question of 20 years. So to conclude, the feature of recording at home and marking the events could facilitate the stimulation setup in the early postoperative period, could help troubleshooting complex situations, could indicate what is the effective therapy threshold, and can empower the patients who are collaborating in marking the events and improving their own treatment, and can also help targeting specific symptoms. And also it forms the basis for the future advances of adaptive stimulation. However, word of caution, there's still a lot that we need to learn, and this still needs further testing before we can blindly trust it for therapy. And thank you for your attention.
Well, thank you very much, Dr. Contarino. Again, a really, really fascinating presentation. And I especially appreciate the fact that it seems that this system will also allow for how can I say, an increased engagement and empowerment of the person who has the system implanted, as they will have the possibility to record their own events, and therefore the physician will receive how can I say, a complete map that comes both from their automatic recording and also the input provided by the person or by the family member. And we all know the importance of obviously tracking symptoms and keeping a diary. So I definitely think this could be something that could be really helpful in this sense. So thank you very much again. Again, we are extremely spot on with time. So as I mentioned at the beginning, we allocated some time for questions. So if any of you who are with us today, if you have any questions for the physicians who held the presentations, or for the presenters from Medtronic, please feel free to either raise your hands virtually or put the questions in the chat. We will record them and answer them as best as possible. Danny, please.
Yeah, hi. I'm very fascinated. I think it's a fantastic idea, whereby we're looking at the actual reactions to the Parkinson's rather than treating the actual symptoms themselves. So I'm very interested in the physiology, and I've just made a few notes based on the very good presentation. Environment is key to understanding how the patient's reacting when on and off with Parkinson's. So environment is key. I just wondered how the actual mechanism reacts in hot, cold, wet, dry situations. So that's a question that I've got for anybody.
Thomas, you want to?
Yeah, I guess for us, there's two things. One is because the entire system is inside the person's body, and it's deep inside. It's mainly the person's body temperature and their body fluids, so all that environment shouldn't change too much. Now, if the extreme cold or extreme heat triggers a change in brain activity, then that's going to change the signal. But right now it's really recording deep inside the brain, which hopefully should not go above 39-40 degrees Celsius when you have a fever, because then it gets really dangerous. But so overall, the inside of the patient's body is pretty standard. Yeah, if the extreme outside conditions affects the patient's brain, then we should see it. But it's more about the effect on the brain that then gets recorded by the device. But the device itself is, in a way, is really encased in it. Yeah.
How does the patient, because obviously you've got a record of the waves fluctuating, but what other record will back up why that is? Like if they're shopping, exercising, in a sauna? So
that's an excellent point. Yeah. So maybe one final point actually about the sauna for extreme things. If you're like a deep sea diver, there are limits to pressure, and it's all in the manual. So really extreme things like super deep diving and so on need to be careful, or hyperbaric chambers, this type of things. But you're right. An important point is outside of the brain, what's happening, what's the actual patient activity. And so that's why these events have to be set up in advance. Like you get 4 types of activities or symptoms that are relevant to the person, but it's based on action and trust. So if people forget, or if they think they have a dyskinesia, but actually they're blocked, they're off, then there's no way. So there's no camera filming people, there's no external watch accelerometry that comes with the device. So that's a limitation. So that's why in certain research studies, you heard about the ADAPT study, for example, the patients can also wear an additional watch, like a smartwatch, that tracks indeed, is the person running or are they lying down? And in that case, it's another device that does the check of what is actually happening. Yeah, but in that case, it's an external device. So it's being used in research, it's being used in science. Actually, some people also use it just because they do it for their sports or their activity tracking or step counting, but it's outside. So it's a great way to do correlations, to do comparisons, but it's not built in right now. We don't have these types of measurements from inside the device.
Is the monitors?
Sorry, if I may add, I think this was a really good question because we mentioned already, we don't know what the effect of different activities, movement especially, is on our signal. And in our experience, I've seen already many times a report like the ones I showed you, and then I looked together with the patient and say, oh yeah, around 3 you were off, and I say no, I wasn't. So maybe something else was happening at that point, and that's still something that we have to study. And as Thomas said, using a watch or asking the patient to fill in a very detailed diary, those are all possible ways of doing it. And this is still a learning phase. We have to realize that this is a phase where we want to collect as much information and to build up as much experience as we can before we can really rely blindly on the signals.
Yeah, I mean, I've had Parkinson's now for nearly 17 years, so I like to think that I'm quite an expert in Parkinson's. And obviously, non-activities, parts of activity like reading or sleeping, they can be misinterpreted if the person's not keeping a detailed record of what they're doing. So I try and advocate people to try and stick to a strict daily regime, which is in line with their natural diurnal circadian rhythms clockwise. So maybe some kind of backup diary would be useful for the patient to enhance the understanding of the technology that you've got, which I think is fantastic.
No, definitely, and especially if, like you're saying, if you have a very stable routine, and then one day you go, I don't know, hiking on a steep hill, that it's great to know for the doctor when you come back. So no, that day I was doing something extreme, and so they can put that in context. I agree. Right now we do need these additional information to make sense of the whole story.
Is it are the people that are being tested, are they people that have got pure Parkinson's, or have they got other underlying health issues which again could distort the readings and misunderstand what's going on? Pacemakers and things like that.
Go ahead, sorry for that.
Yes, so as you've heard, the system is now used in the clinical practice. So everybody who's undergoing DBS can potentially be implanted with this system. So it's not only a specific population, specific kinds of Parkinson. Parallel to this, there are clinical studies going on. And in those clinical studies, because that's the place where we want to learn most, then there might be a selection of which patients are studied in that way and which are not. But nowadays, every patient can get it, even with other indications. So even patients with dystonia or tremor, they could also get the system implanted.
I mean, another thought I've got as well is that some people have a lot of non-motor symptoms like brain fog and stuff like that. And again, that could distort the movements and the understanding of the movement disability.
That's a very interesting point and very important. And there have been studies also looking at the brain activity in relation to, for example, impulse control disorder. And we have to learn much more about it to understand which brain signals can be interpreted in which way, and especially for the non-motor symptoms, this is far more difficult because it's more variable and it's more difficult to collect or to score it somehow as compared to the motor symptoms, but it's a very important point.
Yeah. The only other question I've got down here is touch perspective. Interference from other technology that may again distort the readings.
Yeah, so right now, I mean, I guess the main interference is your own heart. That's the big one. But indeed, if there's defibrillator or these types of extreme things that get triggered, that would definitely impact the signals. Yeah. But here we're talking implants. In terms of things like magnetic interference and so on, I must admit I would have to go back to the engineers as to external, like does your microwave mess up the LFPs? I don't know. I don't have that knowledge yet.
It's just some other thoughts that because we live in a technological world now, so there's a lot of technology out there, and whether these are sensitive to other types of technology that we have in our home.
Yeah. So Thomas, the question here is, does your mobile phone interfere with the recordings, for example?
So that I don't know yet. So far, I don't think so. What we actually care most right now is more about the communication between the device and the programmer. So that there are specific frequency bands that are proprietary and restricted, so that the device talks only to the physician's programmer and not to another, and so on. But for the actual LFP calculation, I haven't seen data of coming from a cell phone or anything, because our own programmer is basically a cell phone. So where it's so far it's designed to perform as possible, but we can look at as we learn about it if there are noise.
I think environment is key to understanding the effectiveness and efficacy of it. Thank you.
Thank you. Sipi?
Thank you. If I understood correctly, the beta frequency is the key issue, the main key issue to this is something that I mean, according to the reading of the beta, you can interpret and understand if there is a high frequency or a high amount, so that's an off, and if it's a low, it's an on, right? So thinking about what you said, Danny, about environment, okay? About environment, if it affects the beta frequency, I mean, outside factors, okay, let's put it, I'll try to start again. I have been diagnosed with Parkinson's 16 years ago, and lately I've been experiencing these fluctuations and on and off situations more frequently. And I realized and I noticed that sometimes when I get stressed and I'm upset, stressed, tired, I get the immediate reaction of the body is off freezing, off situation, and I can pinpoint and say, okay, I get into an off situation because something external, which has to do with my mental state of mind, a very stressful situation, a very frustrating situation. But the bottom line is that the body interprets it, the brain interprets this situation into a symptom, okay? So never mind the reason, I guess that there is it creates a lack of something, or a frequency of beta, let's say, a high frequency, a low frequency, and the result of it is a certain situation I'm in, off or on. In this case, off, okay? So what really fascinates me is the idea that, like what you said at the beginning, okay, with the diabetes thing, that if the device can sense the lack or the overdose of this thing and let me have immediately what I need to get me out of this off situation. So that's a great thing. It's a huge thing. And if it's done, I mean, very close to the situation so that I don't, it's an event, okay? It doesn't happen regularly. So if these events can be taken care of immediately as they happen, that might be a huge change in quality of life because I had this situation for 3 days that I could barely do something, get myself together and just go on with my regular life, you know? So if this can happen, it's a huge thing. So that's for you to be motivated to hurry up with the solution, okay? For at least for people who have this DBS thing. Now, I've been offered the DBS as a solution lately, and I'm very worried about. I don't know if you are the right people to ask, but we're very worried about the change of the cognitive changes and sort of personality changes. What can you tell me about this?
Maybe I start, and I'm sure Dr. Contarino can add. So yeah, there's always a worry from many patients, and I can fully understand that it's also a very big step to undergo brain surgery and have the stimulation. Well, we know that the stimulation can be adjusted over time and according to symptoms and also according to adverse effects that occur. So the subthalamic nucleus, which is the target structure, is a very small nucleus, which not only has a motor area, but also for emotional and cognitive processing. So of course, if the electrode is not well placed or if the stimulation is very high, currents can spread to these areas and they can induce side effects like you described, like impulsivity, for example. But the good thing about the DBS is that we can adjust the stimulation and we can adjust the contacts that we select to keep the stimulated area in the motor area and avoid these side effects. And that mainly belongs to kind of personality changes, which my experience is what patients sometimes report is that they get a little bit more nervous, more impulsive, and that's also an interaction between medication and stimulation. And if we adjust it to the right level, in the vast majority of patients, we don't have this problem anymore. But as you know, also dopamine agonists make this impulsivity, and sometimes this can be even an indication to undergo deep brain stimulation to avoid then these dopamine agonists. In terms of cognitive disturbances, we always have to be very careful for patient selection. So patients that already have a significant cognitive decline should not undergo deep brain stimulation. And we know it can accelerate this for a certain time period, and they will be at the same level maybe a year or two later, but it can accelerate this process. So it is always important to have a very careful evaluation and testing of the patient. So we have a large neuropsychological test battery in all our patients before they undergo deep brain stimulation. And still, of course, there can be patients that have a time period after undergoing the surgery and the general anesthesia, for example, that over several days or sometimes weeks, they have more cognitive problems as before, but usually that comes back to the level that they had before. So it's a key is to select the right patients and avoid surgery in patients that already have cognitive decline.
That's, I think, is obvious, but I still, I think you answered this, but I still insist on the thing that, on the question if the right spot of putting the electrodes, could it be irreversible? I mean,
So maybe I can go on that. Again, I agree on everything that a colleague has said. And of course, the right spot is very crucial. So the lead has to go in the right place. And this is where most centers put their attention. So that if you have surgery in an experienced center, then you can assume that the lead will go to the right place. If everything goes well, the effect of stimulation are reversible. And this is true for the good effect, and this is true for the side effects. There is still a small chance of complication. So you've heard for sure that there is a risk in this surgery of bleeding. The risk is very low. If that happens, that might be not reversible. So that might be permanent. But this is a small percentage. And in that case, yeah, something happened, that complication happened. But if we look in general, now there is a lot of experience with DBS in Parkinson. And if we look at all the statistics or the series that's been published, we can conclude that DBS does not deteriorate cognition in general. And if there is a good screening. So again, what has been said is the most important thing. If you go to an experienced center, you will undergo a full screening before entering the procedure, and the screening gets information on what is your own risk of getting one or another event.
thank you.
Well, if no one else, oh sorry, Gary, go on.
Hi, thanks, Francesco. And thank you, everybody in Medtronic, for this really fascinating display and presentation of what's going on. I'm a little less experienced than Sippy and Danny. I only have Parkinson's for 12 years, so I'm just a kid really on the block. But I do have a question regarding technology. I mean, it's fantastic to see the advances in technology and what it's doing for us. But yet, DBS isn't for everybody with Parkinson's, and it still remains an option for a very small percentage. Does any of the speakers see this changing in the next couple of years? Is that something that's going to be technology driven or personal kind of therapy driven? And if so, what are the comments about what may happen in the future? And by the way, can I just say thank you to each of you as well for dedicating your lives to making my life better. I really appreciate that. I'm very grateful for the work you do.
Thank you very much for this comment. So technically, everybody can get DBS. So from the technical point of view, it's just a matter of making a burr hole and put the lead in the right place. So technically, this is possible. The point is that the best choice for that specific patient? And again, it is a procedure that is safe and is being tested for many years, but still there is a small chance of complications. But these complications can be serious. So every time we propose a new treatment to a person, we always have to evaluate what are the risks and what are the advantages. Of course, if somebody is in an advanced stage of the disease, there is a lot they can win from this treatment. So in that way, the small risk of complications is acceptable. If somebody is in the very beginning of the disease, they can get better with medication and they don't need to have the risk of having a bleeding in the head. And that's why we said, okay, if there is a safer option to obtain the same result, you should always go for the safer option. So that's why we don't propose DBS at the moment of the diagnosis. Now, in between these two extremes that I mentioned, there is a whole range of situations which are not black and white, and the choice of undergoing surgery or not, and when is the best moment to undergo surgery, it needs to be discussed with the person that has to undergo it and with the neurologist. So the neurologist can tell you for your specific case, these are the advantages that you can get in this moment. And these are the risks that you have in this moment. That's the only thing we can say. And then it's the person that has to say, okay, for my experience of the disability, yes, I think it is worth having this risk. So I think this is the fairest way to discuss surgery.
Definitely, and if I can just add from the technical point of view, because this is the medical facts, and they won't change. You know, you need to be levodopa responsive or have all these tests and these checks to know whether the person is indicated for it. From the technology side, what we try, and back to the earlier discussion about reaching the target, we try to make reaching the target easier. So with better imaging, better guiding, we try to have devices that are smaller, that are less visible, that are less intrusive, that are smarter, that have longer battery life or easier to recharge, to make the whole process or easier to program. The idea of sensing is that at the end of the day, it will be easier to program. So I think we're trying to make it more available by making it easier to use, but the actual selection of the people will remain the same for now until we completely change the way we stimulate. So it's I think making it accessible, you know, faster, less intrusive, it should make it easier, so that you don't have to go to one hospital in your country. You know that many hospitals can do it, but yes, the actual patient selection so far still remains the same.
Thank you, Veronica.
Hello, hi everyone. Apologies, I had to miss the beginning of the meeting, so let me know if my question has been answered, and I look forward to catching up on the recording. But yeah, firstly, thank you for this workshop and this presentation, and for the work that you're doing. I echo Gary's comments. My question is regarding the symptoms that are not known to be improved following DBS. So one example in my area of practice is speech and voice, which are not normally helped by DBS. I think in some cases they can also be made worse by somebody undergoing DBS. So I wondered whether with this technology, whether during the research and development of it, or even from the data that's being gathered by patients who are using it, whether they can indicate, you know, changes in speech as one of those events that you mentioned, like you said, they can click if they're having more dyskinesias or off periods or exercise. You know, has there been anything in the research, or maybe since beginning to collect data on whether patients can identify or can make that link between the frequencies and changes in speech and voice, and maybe that would help or has helped to potentially in the future, that might be something that could also be helped by DBS. And maybe if not for speech, for something maybe that, you know, another symptom that was not, is not known to be helped by DBS. Does that make sense?
Do you want to go ahead, Fiona?
Can I ask a question, please?
I think Fiorella,
Yes.
you're on mute.
Yes?
Could not hear you.
No, I am not mute.
No, I was saying Fiorella is.
Okay. The patient who already have DBS could get anything from this program.
Yeah, maybe I'm going to answer this one while Fiorella checks the sound situation. So if you already have DBS, in the case of Medtronic leads already implanted, you can change the stimulator to get a percept that then can do sensing. Obviously, for other companies, there's no plan compatibility, but it's like Dr. Kühn was saying earlier. It could just be a change of device, so the leads don't move, but then you would plug in the new device, which could then start sensing. Mm-hmm. So there may or may not be signal, but there's a way to connect the new device, the percept, to old existing extensions.
Can you hear me now?
Yes, perfectly.
Yeah, sorry, I don't know what happened. So I would like to go back to the previous question, the one about speech. Now, this is very interesting, and this is where all our attention is, those symptoms that we cannot improve and those symptoms that we can get worse with stimulation. So let's start from speech. Speech, we know that can be part of the disease itself. So there is one part of the speech that we would like to improve, and there is another part that we can make worse with stimulation. Now, this new technology can help in that way, in the second part especially, because why does it get worse with stimulation? Is because probably we are giving too much stimulation at one point. As you know, there might be one level of stimulation which is good to improve the symptoms, and then there is another level that introduces side effects, so worsening our speech. If these two levels are very close, sometimes it's very difficult because the best amplitude of stimulation is the same that produces the side effect. So what we think and what has been shown in very preliminary data is that if you use adaptive stimulation, you only use the amount of energy that is needed and not more than that. And this can have a good impact on the side effects, whole deterioration of speech produced by the DBS. So there are very preliminary data that suggest that this could be possible. On the other hand, we have symptoms which do not improve on stimulation. And there, again, we see speech, but we also see freezing, for example. Freezing is a very frustrating symptom. I think at this point, it's too early to say whether this technology will help us in this way, because still after 30 years of DBS, there are a lot of things that we don't know. We don't know exactly why freezing does not react to stimulation at a certain stage. Well, the technology can help is understanding. So maybe we will understand more what are the signals correlated to the freezing, and then maybe there will be another kind of stimulation that we can think to influence those signals. So in that way, if you want to be a bit optimistic, in that way, I think that the technology in the future can also help to solve that problem, but still early. So not yet.
I would fully agree with what Fiorella said. And for the speech, there has been a study on adaptive stimulation that showed that the speech was clearer, was better understandable when adaptive stimulation is on, because it's not this continuous high frequency stimulation. So that is still under laboratory conditions in a small set of patients. So we can't just say it will happen in real life, but it's a first good indication that when you have this side effect of stimulation-induced dysarthria, that can be improved with adaptive stimulation. And we don't know about freezing yet, as has been said, but when we think that the concept is to really cut only the pathological, the abnormal activity, and with the adaptive stimulation, the idea is to leave all the normal processing running in the brain. So that would help to avoid side effects. That's the rationale behind this adaptive stimulation, that we catch the moment when really abnormal activity is very obvious, and we only stimulate in this moment, and the underlying physiological activity is not so much disturbed then as compared to a continuous high frequency stimulation.
Thank you.
Thank you. Danny, I think we still have
yeah, just following on from that. Again, things like food, what you eat, they all have impacts on the brain activity. So again, I think a manual diary of routine is essential to understanding what's happening in the brain.
Absolutely. I mean, there are lots of influences, as you described before already. So there are major brain state changes, and then we have this very local activity that we relate to the bradykinesia in the Parkinsonian patient. But this is, of course, influenced by changes in the whole brain network that are that it undergoes due to emotional states, as has been described, or whatever activity you're doing. And it's only now the time that we can try and learn how this influences the very local beta activity in the Parkinsonian patient, because so far we only have done all our experiments in the laboratory condition, when the patient is sitting on a chair and doing some motor performance like this, which is not like in real life. So it's really the big step to learn a lot more now with the Percept, when we can do these recordings in kind of real life conditions. And that's a great opportunity, and it will really bring us a step forward to really adjust the therapy, not in the lab, but in the real life for the patients. But we still need more knowledge. So we are not quite there yet, but on the right direction, I think.
I wonder whether some kind of cohort study of animal would be of some use.
There are many animal studies. So there are rats, and there are monkey studies, there are rat studies on Parkinsonian-like conditions. But of course, this is never the same. So we can focus on some symptoms that occur in these animals. But then there are pros and cons. I mean, we can learn much more because we can insert more electrodes and can understand how the brain interacts at different sides of the brain, and can simulate some conditions. But then this is far further away from real life, I think, than a patient in our lab.
I mean, also rats are nocturnal creatures anyway as well, so their circadian rhythms are going to be entirely different to human
Absolutely.
beings.
Yes. And not only this.
Yeah. Also, rats don't have the emotional ability either, do they?
Well, we don't know, but they don't tell us.
No.
They definitely don't have to cook and go for shopping and stuff, and take care of the kids, you know.
Yeah. They don't freeze either.
Yeah, I think it's very, very interesting and a fantastic idea. And technology is the way forward, and we have to embrace that, I think.
All right. Well, we are 4 minutes from the end. Is there any more question from anyone? Doesn't look like. So, yeah, I would like to again thank you all very much for being here with us today. Well, the Medtronic team for explaining so in depth about the technology. Professor Kühn and Dr. Contarino for going over the application both in clinic and outside the clinic. And I especially found fascinating, and I think that's the most potential of this could be relating to improving the communication also with healthcare professionals, with consultations, which we know is so important for people living with the condition, and also empowering and engaging people to improve the self-management and the adaptation of their own therapy. So yeah, hopefully, what can I say? Keep us updated, obviously, about the further developments of this technology, and we hope to see new improvements very, very soon. And I'm sure all the Parkinson's community will be interested in hearing about this. And a special thanks to the attendees today who were very engaged and posed very, very in-depth and very pertinent questions. And I think we all learned, we really learned a lot. As I was mentioning at the beginning, this is kind of the first kind of webinar of this kind that we conduct. So if you don't mind, we would be very happy to hear your feedback about this. I mean, did you find it useful? Did you find it engaging? What could be improved? So as a follow-up to this call, in the next days, I will share with all of you who kindly attended today a very, very short survey in which you can very honestly tell us what was your perception and feedback on the event. And as mentioning, this session has been recorded, and we will look into developing it into a resource that could be further shared with the EPDA audience, because I think the information that was shared today is really, really important, and it doesn't happen every day to have two very experienced physicians going so in detail about the application of this treatment technology. And I think it's very important that the whole community knows more about this.